Hi, Barry. Thank you for being on today and discussing your recent paper in JACC, Tricuspid Regurgitation across the spectrum of heart failure with preserved ejection fraction. Thanks for being on today.
Thanks for having me.
I'll just kind of share a few points that I thought were really interesting from your paper. One was that in REST, HFpEF, and PVD cohort, the VSTR prevalence was about 26%. ASTR was only about 8%. So making that VSTR the most dominant phenotype of TR in the HFpEF spectrum. The other part that I thought was really interesting was that the RA volume was significantly higher in the VSTR group compared to the ASTR group, about 20 milliliters of difference that you guys found. And the third part was that methodologically, when you guys adjusted for the fact that not only one of 5 characteristics had to be met in order for it to be labeled as VSTR, maybe only then you guys made it more stringent and said 2 of 5 had to be met. The results didn't really change much at all, which sort of was a really nice finding to sort of shore up the results. So I'd just love to hear what you thought were the big takeaways for someone reading this paper.
Yeah, thanks. Well, I think the takeaways for me are that significant TR is pretty common in HFpEF, even in these early stage patients, but it's clearly associated with the presence of pulmonary vascular disease, defined by an elevated pulmonary vascular resistance, either even among people at rest or with exercise-induced elevation in filling pressures. Now, you mentioned that the type of TR. We generally people sort of categorize or conceptualize, ventricular TR is more HFrEF and atrial TR is more HFpEF. But here we observed that there was a preponderance of ventricular secondary TR in patients with HFpEF. And that really sort of drove the gradient from people with exercise only and no pulmonary vascular disease up to resting HFpEF with pulmonary vascular disease. I think it has more to do with the way that we categorize it. We use criteria that have been proposed and widely used. But in fact, as you point out, we saw that even though they have what we categorize as ventricular TR, their right atrial volumes were more dramatic in the patients with so-called ventricular, and the prevalence of atrial fibrillation, which we think is so strongly related to this atrial TR, was basically equal in ventricular and atrial. So, maybe at least in the setting of HFpEF, we need to think of this as sort of a combined atrial ventricular TR, and I think that's probably the way that I would, step away from these data. It's not just ventricular, but they do have findings of ventricular TR in terms of ventricular dysfunction remodeling, and those travel with pulmonary vascular disease. So I think that's a big takeaway. And we included some patients that don't even have HFpEF, that just had pulmonary hypertension that was more of a precapillary etiology. And in that cohort, TR again was strongly related to the presence of pulmonary vascular disease. So it really seems to be a common theme.
Yeah, I think something that you pointed out was that, sort of current guidelines use atrial fibrillation or the history of it to define ASTR, right? And I think you guys showed that maybe 46% of people with ASTR in your guys' cohort didn't have a history of AFib. And so it sort of speaks to the fact that, like, you can't use AFib as a sort of diagnostic criteria in a place where I think, and maybe clinicians are sort of used to sort of thinking about it in that framework.
Exactly. Yep. I think that was another interesting observation.
So kind of looking more broadly, how would you start to think about a patient who has HFpEF and on the echo you see that the read, or maybe you look at it and see that, hey, VSTR is pretty likely based on maybe they meet 2 out of the 5 criteria. So I'd love for you to maybe kind of walk me through how you think about that patient, because the nice part is you don't need a right heart cath to sort of get data on VSTR versus ASTR, right? And you guys show through your guys' modeling that VSTR has a much more severe phenotype associated with heart failure, hospitalizations, and mortality, and the hazard ratios are significant. So you can kind of get a lot of data from just the echo now, right? So I'd love for you to kind of, walk me through that.
Yeah, I think when you see this, it's TR. And unfortunately, I think what happens too often is it's labeled as just TR. It's just symptomatic tricuspid regurgitation. When in fact, TR is hardly ever just by itself. It's secondary to something else. And, one of the most common secondary causes is heart failure with preserved ejection fraction. So a lot of times what kind of hits people over the head is they see this tricuspid regurgitation, they see this right ventricular remodeling or dysfunction, and they're like, oh, it's TR. But I think the reminder here is that you got to be thinking about HFpEF. And really, this is more severe HFpEF. As we show, the presence of ventricular STR was really associated with increased risk for both heart failure hospitalization and all-cause death. So that's a patient where the priority to get them started on treatment is even higher than it is in others. We want to get them started on guideline-directed medical therapy. You're not going to treat, do a transcutaneous tricuspid valve intervention for somebody with just moderate TR, but you're going to want to be watching them closely, get them on a loop diuretic if appropriate, get them on an SGLT2 inhibitor, get them on an MRA. So these are all the things that I would be thinking about. And then again, just thinking, is this HFpEF? Do I need to do more workup to see if this is really TR due to HFpEF? Because most often, I think in this sort of setting with a normal ejection fraction, that's going to be the underlying cause.
Yeah, and it's interesting that you pointed out the fact that VSTR is associated with both rest and exercise HFpEF, right? So you can't really get that data without doing that exercise component, or at least the feed up component of the exam, right? Like when you do the cath and kind of what you're saying, which is when you see this patient with this sort of, we're calling it VSTR, this mixed mechanism, you're going to try to get them into the cath lab, much faster than if someone maybe didn't have that. And then also think about the exercise component, which I think, and I'll maybe have you comment on like how frequently that gets done, right? Because there are more resources involved with that exercise component. Feed up is definitely easier, but exercise requires a lot more resources.
Yeah. I mean, I think it was an important observation was that significant tricuspid regurgitation was present even among people who only had HFpEF that was apparent during exercise. In the absence of the exercise testing, you would not have said that they had HFpEF. You would have just said they just have tricuspid regurgitation. But none of the patients with non-cardiac dyspnea had tricuspid regurgitation of that severity. So it is, TR does definitely get worse with more pulmonary vascular disease, with more advanced HFpEF. But we show here that it's present in, about 1 in 9 patients with even exercise-induced elevation in left heart filling pressures. We're really pushing to try to get more laboratories to do this. The number of labs in the U.S. and worldwide that are doing it is increasing, but it needs to increase more. And I think that any lab that prides itself on being a significant referral labs that do MitraClips and TAVRs and things like that, they should also have the capacity to do exercise hemodynamic testing because it really is a key gold standard test for the evaluation of HFpEF.
Yeah, absolutely. And I, kind of thinking about the instrumentation, you guys kind of assembled this cohort across maybe 16 years, right? And things change over time, and the way that we measure things change. I mean, that the visualization that we had on an echo 20 years ago is definitely different than we had today. So I just love, you guys showed inter-rater reliability, and then the random samples is very consistent. So that maybe necessarily wasn't a big concern for your guys' work, but I'm just sort of thinking about when you're measuring these hemodynamic parameters, maybe over 20 years, right? Maybe not just labeling moderate TR versus severe TR, but thinking about PVR measurements and sort of like the waveforms and how maybe that equipment has changed over 20 years. And if you think that there was a drift in one way or the other, or sort of like random variation.
I mean, it's always a good thing to think about. Now, I didn't do every one of these caths, but I sure did a lot of them. And I've been doing it the exact same way since I came on staff at the Mayo Clinic in 2006. And I think that's true of my colleagues too. We're very consistent in the methods that we use, and it really hasn't changed during that time. So I think that those data are reliable, and they're not. There's no secular trend related to different methodologies that could change that. Obviously, echo technology has changed. We're using things like speckle tracking strain more these days and 3D echo. Those modalities were not used in this study. So we used more, sort of lower tech, relatively speaking, echo variables that didn't really change during the study period.
Yeah, that makes sense. And I think the point that I want to think about a little bit more and maybe get your comments on is you guys did this sort of sub-analysis of looking at only patients who received an echo within 30 days of getting their right heart cath, and then looking at the composite measure of heart failure exacerbation and mortality. And, it's broadly consistent, which is, I think, a good thing, meaning that, maybe if someone got an echo 2 months before, it didn't necessarily impact the prognostic value of these things. But the one thing that I noticed was that the hazard ratio on the VSTR in this multivariable Cox was lower, right? I mean, the lower bound of the 95% confidence interval was 1.01, right? I mean, so I think, there's definitely a downweighting of the importance that VSTR plays for some reason when the index cath happens less than 30 days from the echo. So I don't know what to make of that, but I just thought that was an interesting finding, and if you had any comments on that.
Well, I wouldn't overinterpret that because, anytime you do a sensitivity analysis, you're decreasing the sample size because you're looking at a subpopulation. And when you decrease the sample size, you increase your likelihood of type 2 error or, falsely concluding that something is not significant when in fact it is. That didn't happen here, but it got closer to that, as you point out, with the lower confidence interval being, closer to unity. But I think that we just have to look at the entirety of the data and make sure that things are at least internally consistent. I wouldn't conclude from this that there was a difference in patients with more recent echocardiography. I would just conclude that it was a smaller sample size, so the reliability of the estimate is going to be a little lower.
Yeah, yeah. That's a good point in terms of sample size and limitations around that. I think my sort of last question to you is sort of around ASTR being significantly associated with heart failure hospitalizations, and just sort of armchair thoughts on why that may be the case versus not mortality per se.
It makes sense because, as we showed here, as we talked about at the beginning of this, that, the atrial myopathy, the atrial dysfunction and atrial remodeling was even more severe in the VSTR patients than in the ASTR patients. So if you have more severe atrial myopathy and you have RV dysfunction, it makes sense that you're going to have worse outcomes. And so that makes sense that's why they had a higher risk of both mortality and heart failure hospitalizations. The ASTR patients, they don't have the right ventricular dysfunction, so they're probably not as advanced. They've got better RVPA coupling, better reserve, so it makes sense that they might not have higher mortality. I mean, the point estimate was still favoring an increased risk. It's just that it wasn't statistically significant.
Mm-hmm.
And again, you come down to issues with power. Do we have enough events to see that? So I'm reluctant to conclude that atrial TR is not associated with increased mortality from our data because we have a smaller sample size. But we do see that it's associated with higher risk of hospitalization, and that makes sense. And we've shown that in other studies where we've specifically focused on, left or right atrial or biatrial myopathy. We very consistently see that that's a marker of increased risk.
Yeah, that's a good point, and I think that's maybe some of the. I think a lot of these right heart cath data sets that I've seen are, it's hard to get to thousands of patients because at least I haven't seen that, and I think that might be sort of a general limitation of doing multivariate regressions on it. So I guess closing thoughts if you have any, and sort of looking forward, what maybe some interesting questions are that you guys are pursuing or that you think just like the field should be thinking about in this space with maybe PH, HFpEF, and the sort of VSTR, ASTR spectrum.
The main takeaways here are just that TR is very common in HFpEF, and that among people who are presenting with TR, or that's what's initially noticed, we need to be thinking about heart failure with preserved ejection fraction as the cause. And TR and worsening TR is really strongly associated with the presence of pulmonary vascular disease. We don't have specific treatments right now for pulmonary vascular disease associated with HFpEF, but we hope that that's for the time only. There's intense work underway right now, a number of different drugs and even devices and approaches to treat this kind of pulmonary vascular disease, potentially anti-remodeling therapies. So I think it's just a matter of time. So understanding that when you see the TR, that's the kind of patient that you're looking at, that means you know that they're at higher risk. We need to get the right diagnosis, figure out if they have HFpEF, get them on GDMT. We need to have a conversation with them that they are at a higher risk, they're a more advanced stage of disease, and it just increases the priority for pursuing more treatments that are directed at that. And then, of course, monitoring for progression of tricuspid regurgitation, because we have a number of newer treatments for tricuspid regurgitation now. Not yet studied in a randomized trial in HFpEF specifically, but certainly something to want to be thinking about clinically, once it becomes more severe.
Awesome. Thanks, Barry, for your time today, and great paper. Really enjoyed reading it.
Thanks very much.